And that might be fear-provoking. Like, I mean,
well, I would not encourage you to do that.
Right.
Right. But that's no different than what we're going to teach you anyway, right? Anxiety is not always bad. It is biologically there to be an alarm. To let you know, okay, that door, it looks like maybe I should not go through that door. You are assuming that there's danger on the other side, but you have intuition, you have wisdom. You are allowed to leverage it. But you don't have that about each individual, especially upon meeting them. Now, after even after 10 minutes, you might be able to determine, okay, this guy, he's an unsafe guy. I don't want to continue to engage with this person. But just by looking at him, it's harder to do. Not impossible, but it's harder to do.
Yeah.
All right, well, this is another episode of Mental Health Monday. Appreciate y'all for pulling up. Here with my guest, Dani. What's good? What's good? Slim, what's good? Appreciate the red, like the burgundy. Every time.
We're color coordinating. Except for Juice's
slippers.
Tan pants.
Tell the folks who you are and what it is that you do.
My name is Dan, or Dani. I am a behavioral health therapist, licensed in Maryland and DC. And I've been operating in that space for about 1.5 years now. And I am on the path towards broadening my engagement in the industry and what I'm going to offer to people who need services, especially people of color, people of the LGBT community looking for affirmative care. And I'm just, here to chop it up with you guys. That's cool.
Of course.
Yeah, you're always cool in my book.
I appreciate it.
So, tell me about your day.
Tell you about my day.
Yeah.
My day so far, not too bad.
Okay.
Normally, I don't work on Thursdays, but had a little bit of a crisis moment with a client, which does call me into work. And then I had to, luckily, I was able to go to the gym before that.
Okay.
So I was fresh and I was relaxed and I could handle that. So I'm going to sit down, I'm going to have this conversation with you guys, and then I'm going to go continue to address that crisis.
You're mid-crisis.
Office stop. So, tell me about the significance of the gym.
The significance of the gym?
Yeah, for you.
For me, it's physical movement, and I think that should be significant for everybody. You get to choose how you execute the mission of physical movement, but I prefer the gym. Because you get the benefit of physical movement, you get a sense of accomplishment, which I need personally. And then discipline. I have to find one thing to stick to. If I don't, then I feel like I am letting myself down, for lack of better terms. I consider myself an accomplished person, so if I'm not in school or something, I have to find something. So I need something where 3 months from now I can see my progress, and the gym facilitates that.
Does it also double for like getting rid of excess energy for like emergency days or like stress days?
Sometimes, because it's not always a reactive tool, right? It's not always that there's a stressful day or a crisis and then you go to the gym. Sometimes the gym is prep for the day. I need a sense of calm to be able to assist anybody else. If I'm of all attention, then I'm gonna start, my mind's wandering while you're talking, and I don't think that benefits anybody. So, no, I don't think it's just like medicine, but it's prep.
Okay.
For me.
Okay. So, you're a therapist.
That is what they say. Yeah.
Whoa. Can you explain? Elaborate on that?
I am a therapist. I'm a new therapist.
Okay.
So I'm new to the field. I've had clients for like 1.5 years, but I just got my license maybe 6 months ago. So I love the title of therapist. I'm still getting used to labeling myself that way. But Yeah, I guess I'm a therapist.
Okay.
What's the difference between what you were doing a year ago and what you're doing now? Like,
Okay. Well, let me ask you a question about your question. So when you said a year ago, you mean like before I was a therapist, or like literally?
yeah. No, I'm saying like you said you've been seeing patients or seeing clients for 18 months.
Yeah.
And then you just got your license 6 months ago. So like,
Before that.
Yeah, in terms of like how you feel, why you said like they say that I'm a therapist, like you've got a year and a half of experience, you know, that counts for something, right? It's not like you just jumped out of the box and like, oh, I'm seeing clients now, I have a license.
I got you.
Yeah.
I'm gonna try to hold the answer in mind.
Yeah, it doesn't normally happen like this. Usually it's quiet. I actually left my phone in the other room.
Yeah, I should have did the same.
You have time now. I mean, we're paused.
You can't see it, can you?
He's gonna cut it out. Like
you can't.
oh, see your phone? Oh no. Yeah.
So you guys do this every day, or like?
No. It depends on like guest availability, right? So, you know.
You're not only talking to therapists, are you?
No. People who have mental illnesses. Yeah. People who have family members who have it, you know, have things.
I got you.
We're starting a new structure. Previously, Juice was just like, somebody said they wanted to come on the show, then he was like, okay, come on. But now it's like we have a list of diagnoses that we want to expound on, and we're going to try to get a patient, a therapist, and a family member for each diagnosis.
Okay. Okay, what are they?
He wants to focus on depression, anxiety, and bipolar. So those are most of our episodes. And then we also put in like schizophrenia, OCD, personality disorders, ADHD, PTSD.
You have all of these lined up already, or
No,
okay?
we're recruiting. So if you know anybody, we would love that rec.
Okay.
Yeah.
Okay. And you want like the diagnosed person? You want their actual therapist, or like just a therapist?
No, it could be a therapist that specializes in that.
Okay.
So like I heard that you said that you specialize in like anxiety and OCD, compulsive. You said compulsive things.
Well,
I forget your exact wording, but you said like compulsory.
it's anxiety, but it's like obsessive thinking. But OCD is very difficult to address.
Oh yeah.
I would not call myself an OCD specialist.
What's the difference between obsessive thinking and OCD?
There's usually a behavior associated with the obsessive thought, and it's hard to get people to do the opposite of the urge for the current behavior. That is a lot harder than obsessive thinking. Obsessive thinking is like, let's say you text a friend and they leave you on red for an hour and you're like, oh my god, they don't want my friend anymore. There's something wrong with me. They must be out cheating on me. Like all this stuff, and it's just like, that's easier because there's often not a lot to back that up. And then some people are softer than others. So people who can take a little bit of a stronger approach, you can kind of be like, well, what if they are?
Yeah.
Everybody's not receptive to that, but what if they are? You wouldn't know.
Right.
So is that really how you want to spend the next hour?
How does a person stop obsessive thinking though? Like there's no, I mean like, yes, it is disruptive and like it can hinder them because they can't move past that and do other things, but like there's no action behind it. It's not like you're turning a key for 30 minutes or like washing your hands for an hour. Like, you know, like how it's more difficult. I would think it's more difficult to change the obsessive thinking, right? Like,
You think so?
I do. Cause like you're holding yourself accountable, right? Because you're thinking the thoughts. Nobody else is like, oh, you should stop doing that, or like,
Right.
you know.
Right.
Yeah.
So you're thinking the thoughts.
Yeah.
Okay. And you have control over the thoughts in the same way you have control over the behavior in terms of their frequency and duration.
I would say you don't have control over the thoughts.
Okay.
Okay, yeah.
So, I love these conversations. Why you don't have control over your thoughts?
Because thoughts just come in and...
They do.
I mean, you can't control what comes in.
That's true.
Yeah.
That is true. Mm-hmm. Okay.
Yeah, so that's why it's harder to control thoughts.
Well, it depends on what you think about a thought. It does. You can be a spectator of a thought and not a participant of a thought. So you have too many thoughts in one day to engage all of them. Mm-hmm. Right?
Yeah.
So if you engage a thought that is not serving you too deeply, you will ruminate and you're going to spiral. You're going to go down a rabbit hole. Mm-hmm. You could say, as a spectator, they did leave me on red for an hour, and I am fearful about what they may be doing, because in my past I've experienced betrayal. Mm-hmm. Okay. You've acknowledged your feelings. You've accepted why you have that thought and that feeling. Mm-hmm. At that point, you get to decide if you're going to participate in the thought. Okay? So, if you participate, then you go down the rabbit hole of betrayal. You begin to ruminate on what they may be doing, and it's often projection of what the previous person was doing. Mm-hmm. And that takes up a lot of time and a lot of energy that you don't have to do.
Yeah.
That is easier, from my perspective, than trying to get someone to stop flicking a light switch 50 times. Because the light switch, the compulsive behavior, you cannot be a spectator of behavior. You have to participate in flicking the light switch. It is an urge. A thought is not an urge.
Okay. Very nice. Thank you.
Sound like a gem. What was that about?
How do we get there? Obsessive thinking is what do you call it? Something that falls under the umbrella of anxiety. Mm-hmm. Being a little bit easier to address than OCD, because that's a behavior thing. And I'm not at the point of specializing in addressing that kind of behavior.
But OCD also falls under the umbrella of anxiety?
Yes. I believe so. At one point, I think there was, in the DSM, they were going to move it. They may have moved it. And I don't want to give you misinformation. But yeah.
For the people, what is the DSM?
What is the DSM?
For the people, yeah.
It's our Bible. It's our diagnostic dictionary. Mm-hmm. It gives me the boxes to check off based on what you tell me of your experience. Mm-hmm. If you check off a certain number of boxes, it's possible that you have that diagnosis.
Are they on the DSM-6 yet? No. Still the DSM-5. Okay.
Say it like it's Jordan's. Damn, it's kind of hard. When you were in school, what would you say was the best piece of advice that you got prior to becoming a therapist?
Wait, can we go back to the question that I asked before you got up?
What was the question?
You remember? It was...
What was I doing before this?
What's the difference between what you were doing 18 or, a year ago compared to now?
Okay, so what I was doing before therapy, for about 8 years, I was a federal contractor. Mm-hmm. So I spent most of my day, and this wasn't necessarily different, at whatever agency I was assigned to, because there was a few. And I would have essentially a client or a group of clients. And I would spend my day listening to the things that they don't like about whatever project or process they are engaged in. What you don't like about it, what's annoying about it, why is it not working, and what you don't understand. So you go to work every day and you do something one particular way and you don't know why you have to do it that way, but you do it and it's painful and you know it's ineffective and not efficient. So I spend my day and I listen to that. And then I map it out, and then I take that map and I work with a team of developers to automate a way to relieve your pain points. So if you're tired of physically emailing a random Word document back and forth, we'll build a system, takes in the document, It does whatever you would normally do, pen and paper, and then it sends it out. So you get less stress, the other person gets the same product, and there's just more efficiency. And I would do that all day. And I did not enjoy that. I enjoyed listening to people, but my attention often left the document or the tool that we're building. And I would start to like hyper focus on like, why is that annoying to you? Like that seems like such a simple thing. Like your thought process, like there's so many things to worry about. Like why is the font color of this thing bothering you so deeply? I did not understand that, but I wanted to understand that because there are things that are important to people even though they're not important to me. And I felt myself starting to minimize what was important to them because it was ridiculous to me. But that I could address, right? Not projecting onto people. But I could not get over the desire to just focus on the thought process. And so I pivoted. But I pivoted back to what was always my original plan. So when I started undergrad, I was a psych major. And then life got in the way and I had to change it. But life goes on, you can change it back. So I did. I have a tendency to do what I want to do. So far it's working for me. But does that answer your question?
No.
Okay.
So like you had started out by saying, they say I'm a therapist.
They do.
Right. But you just been licensed for 6 months.
Right.
But you've been seeing clients for 18 months.
I have.
So how is you having your license change anything that you were doing in those 18 months?
It doesn't. It doesn't. It's just a new step in the process, right? It's a graduate level license. I think that I would, even though I can confidently say right now, okay, yes, I'm a therapist, there's added confidence, I think, or security with having the full license, right? I still am in the process where I need to complete supervised treatment. So yes, I am a therapist, but I'm a supervised therapist. I'm not against supervision, but there will come a point in my career where I don't need to be supervised. Maybe I can supervise other people. It is another level of being a therapist. So yes, I say that that's what they say, because there are people who will tell you, no, you have a license to be a counselor, you're a counselor. So sometimes it's like, well, use whatever word you want to use, but the work is generally the same.
How much longer do you have before you get to that level where you're unsupervised?
Oh, at least a year and a half.
Oh, okay.
It takes 2,000 supervised hours to get there. But it's just a formality. It's just a process. For me, I think it's a bigger decision is whether or not I'm going to pursue the doctorate than whether or not I'm going to get the license. But whether or not I get the doctorate is still a question.
Yeah.
When it comes to the supervision process, as you go through becoming a therapist, would you say that opens the door for you to be able to reach back for pieces of advice if need be when it comes to your development as a therapist?
For me, yes. All supervisors are not created equal. There are some that you may not want to look back to or return to. Some of them can mirror any supervisor you've ever had in terms of like being a micromanager or anything like that. I just happen to be with someone who believes in autonomy. For the most part, I am very independent. She works with me as if I am a person and not an employee, if that makes sense. So it would be easy to reach back to her. And I like her style. I think that matters. I think the longer you do it, the clearer your style will become, and some supervisors are just not going to be suitable for where you're trying to go. They can push their preferred interventions, their preferred styles and modalities and things, and it just might not be where you want to specialize in the future. So it really wouldn't benefit you to a certain extent to look back. And that's not really the case for me.
What's your focus as a therapist in terms of when clients reach out to you?
When they reach out to me? Well, it depends what you mean. So when they reach out to me,
I fill it in. Like, let's say someone's looking for a therapist that focuses on anxiety, or a therapist that focuses on ADHD. What are your focuses as a therapist when a client reaches out to you? Like, in terms of subject matter that you're like, oh yeah, nah, that's my bag.
Okay, I got you. Okay. So, there's different levels of anxiety, right? Some are more severe than others. If someone is having anxiety because of some life transition, I got that. If someone is having anxiety because of patterns or habits that they find difficult to break, and it's preventing them from having the life satisfaction that they desire, I got that. For example, I'll give you an example. Let's say you want to work on being a more independent, confident, secure person. You want to be the type of person that isn't as fearful of doing things by yourself, right? You go to a restaurant by yourself, you go to movies by yourself. Some people may be so anxious, so focused on what other people might think when they see them doing something by themselves, that they fall into a pattern or a habit of just not doing the thing. Okay, that disrupts the potential for greater life satisfaction, because you want to be doing the thing, but you don't want to continue to wait on someone to do it with. There's some anxiety behind, or that's driving the continued engagement in the pattern. So we can work through the pattern and some of the emotions that are underlying the anxiety, like the shame you might feel sitting by yourself or having to do it by yourself. That, I feel, is not the most severe end of like the anxious spectrum. There are other levels that may require a specialist for that.
Would you say OCD is the severe end of the spectrum?
It can be. It can be. And it's also something that a person may be more responsive to interventions and modalities that I don't specialize in. There are things like ERP and stuff like that that I don't.
What's ERP?
It's a responsiveness form of treatment. The behavior that you engage in is really a response, which I have not been trained to do. I do more like CBT, DBT sort of stuff, which is helpful for more like manageable levels of anxiety. So I can do that. I also tend to work with a lot of people who, after you talk to them, fall under the ADHD umbrella. And they might come in with something like, I just can't find the motivation to do stuff. I'm always procrastinating. I just don't know why I can't just get started. You know, that kind of stuff. Like, I have all these goals and I don't know what to do, or I don't know how to come up with a goal at all. That's usually some executive dysfunction stuff that we can work through. Sometimes there's some overlap with like depressive symptoms in there, but I wouldn't say that major depression specifically is my bag. Yeah, that's not mine. in the back.
So how do you determine, like, okay, the CBT and DBT is not going to be enough for this person. They might need medication. How do you assess that?
Okay. So to some extent, I don't. Because I cannot prescribe you anything. What I can do, though, is explore your feelings about medication. So I may just intuitively believe that you might benefit from the medication. I'm not going to suggest that you get medicated. I'm not going to force you to get medicated. But I can ask you, you know, based on what you're sharing with me, it seems like for a long time, a very long time, you've struggled to manage this on your own. And I'm not the first therapist that you've seen. And some of the techniques you've been trying, they've been working, but you still feel like it's not strong enough. How would you feel about incorporating medication into your treatment? If you say yes, I can work with you from there, right? Provide you some resources. If you do begin the medication, work with you to stay on top of your medication. But if you say no, then we'll continue on the way we're continuing on, and we'll tweak what we need to tweak to make the outcome a little bit more beneficial for you. But it's not for me to say.
Yeah. So for people who have been in therapy, let's say for 3 months for anxiety, and they don't feel like it's making a difference, and they're like, oh, I need some Xanax. Would you say that's enough time to make that assessment, or would you say you probably need to stick with what we're trying a little bit longer, or maybe get another therapist? How should the common person go about like deciding whether or not they've tried non-medication routes before they switch?
Okay, it's a good question. In some ways, the same answer applies. It's 3 months to me and 3 months to you are different. So it is not for me to say. And the reason for that is that autonomy in therapy is important, right? It's the same reason why we're not supposed to give advice. Okay, I don't give advice. I can tell you exactly what to go out and do, right? I can tell you to go get medication, but you don't need me to tell you to get medication. You have all the answers. They might be locked away or hard to access, but you have the answers. My job is to give you the tools to unlock that, to be confident and secure enough to make decisions. It is not to tell you exactly what to do. Because when there's no longer access to me, what are you going to do? There's not going to be a me to tell you to go get medication, or to tell you how to respond to someone, or how to move past a thought that isn't serving you. I'm a teacher, a skills trainer, but you are your own person. So if you want medication after 3 months, and you can say to me you have justifiable reasons for wanting it after 3 months, okay, I'll give you resources. Here's the Rolodex of psychiatrists that we are aware of. If you want to contact them, you'll contact them.
Yeah.
But it's not for me to decide.
Yeah.
Have you ever found pushback with that mindset when it comes to clients? Like they want to be told what to do, or they'd rather you give them as much advice as possible?
Well, yeah, I mean, because it's easier that way, right? And it's what people often think therapy is. Some people will tell you, I'm not going to therapy. I don't need somebody to tell me what to do with my life. I know what I'm doing. Okay, you do know what you're doing. Do you want to continue to do it that way? You know, like that is not what the service is for. But yes, people do want that. But it's not hard to push back. You know, somebody might ask you, well, what do I say to this person? Well, I can't tell you because it'll sound like me. That's an easy pushback without saying, I'm not gonna do that for you, because you don't want to do that, and they don't feel like they don't have any support, or the rapport is like damaged. You don't want to do that. But it's not hard to push back. You just have to kind of remind them like what they are in therapy for. And it is not to walk out the door and do everything the way that I would do it, because I don't have the full context of your life. I know some stuff, but you're not going to go out in the world and get in trouble and say, oh, my therapist told me to do this. I can't do it. I can't do that. And it's not that difficult to walk people backwards and just say, like, if you ask me what should I do about this, and I asked you, what do you think you should do? I didn't have to tell you no, or I'm not going to tell you, but it's just, what do you think? And then maybe we can talk about your thought process and why maybe that line of thinking isn't helpful. But I'm not going to tell you what to think and what to do. Most likely you've come to therapy because you've had enough of that in your life.
I find some people believe that going to therapy, especially as it's become more trendy, they think it's going to fix everything. Like, oh, I'm in therapy, so it's going to fix everything. They don't recognize that an investment is necessary on their end. Like, you have to do the things that your therapist is maybe suggesting, or like, you know, attend to the disruptive thinking patterns that have gotten you to this place. People don't think that's necessary. They think the therapist is going to fix everything.
How though? Like how? Like if the answers were so clear, right, that a therapist could fix everything, then the average person would have the same skills. It would be clearer to a broader percentage of the population. So how am I a magician?
Yeah.
I would love to be, but
yeah,
that would be unfair to you, because now I've just done it for you. You don't want that. Well, I guess some people do want that. But why do you want that?
Because people don't want to work hard anymore.
Why?
Soft life? I don't know.
See? Then we get to the point of I don't know. So do you really want that? You're not even sure why you want that. So how do you know that's really what you want? You just want to get over the thing real fast.
Yeah.
Okay. Okay. Well, you got to go through it before you get over it. I don't know if I really believe in getting over things. Get through things. I don't know if you really get over things. So I'm not here to like carry you over. I can give you the tools to get through. If you don't want them, that is your choice. You are free to wait for someone who can just tell you exactly what to do.
Yeah.
Even though you don't know why you want that.
And I guess the tools are only as useful as the person that's willing to really use them.
It takes time.
Yeah.
It takes time. People could think right away that it's like, oh, that makes sense. Like, that probably would work. And then it'll take a few months to actually start doing it. But that's okay. I've got patience. I've got time. You got to be a little patient, though.
Yeah. It might be the way that society has gone, because even as a pediatrician, like, I'm sitting here, again, as a guide, I can't go home with you and tell you every right thing to do, but if, you know, let's say obesity is one of the things that I struggle the most with in terms of convincing somebody that they need to make changes. I think with Ozempic and like all these injections and things, like people see like, oh, it can happen fast and I can still have my cupcakes. Yeah. And so it's this new line of thought where we want to have our cake and eat it too, literally, like, you know. And so I imagine it probably makes it harder for people who are coming to therapy, like, to think or to understand that they have to do things a different way. Like, it's not going to be the way that everything else. It's not Instagram. It's not TikTok. It's not, you know, scamming. It's not like, you know what I mean? Like, you have to work hard.
There was something you said earlier about executive functions. Can you tell me more about that?
So executive functioning is what people with ADHD often believe is normal. So I wish I could just be normal. I wish I could just get out of bed and start my day and be organized and have perfect task activation, perfect time management, self-motivation, everything that you think is a normal high-functioning person is doing. Which normal is like, I hate that word, but what you think an accomplished person is doing. They can self-organize, they can get things done, they can manage their time, they can wake up and seize the day. Executive dysfunction is the opposite of all of that. That's where you have things like procrastination or missing meetings, the friend that's always late, that kind of stuff. After a while, that kind of stuff becomes a problem for most people. Especially people who don't want to be medicated. It's not, but I don't think it, honestly, it's not an easy thing to get past. It's not, because of just, I think, societal norms. So someone might tell you like, oh, I have this thing I really want to work on and I'm just having a hard time getting started. And they might tell you, just do it. Like, you know you want to do it, just do it. And they'll say, I can't. That's executive dysfunction. The I can't. And they really can't. Not with the level of skills that they have at the time. You can learn new skills though. Does that answer your question?
For me, it did.
Are there things besides ADHD or ADD that fall under executive dysfunction?
Oh yeah, you mean like diagnostically? Mm-hmm. Yeah, I mean executive dysfunction. It's like it's not like a disorder you're gonna find in DSM. It's
an umbrella term that describes many things.
Many symptoms, mm-hmm. many behaviors, mm-hmm. yeah, or challenges.
Yeah.
Yeah, so it can fall under other umbrellas. It can, like, depression, for example. It can be easily associated with depression. Because there's a spiral. Mm-hmm. Okay, so let's say I procrastinate a lot. I don't want to start the thing because I'm a perfectionist. And I feel like if the outcome or what I produce is not going to be perfect, I'm not going to start. Then I fall into the pattern of just not starting. Mm-hmm. With that pattern, now I develop a lot of shame and a lot of comparisons to other people. And now I'm so ashamed of my inactivity. I've compared myself so much that now I'm having depressive symptoms. Right now I'm not concentrating. Now I'm not finding it easy to motivate myself. Mm-hmm. Now I don't want to engage with people who I think or that I'm comparing myself to. It is I want to call it a precursor to a lot of things.
When it comes to representation within the sphere of therapy, what are you looking to make a difference in group-wise and representation?
I mean, I definitely want to broaden my client base to include more people of color. That is not necessarily the case right now, but that's just the nature of where my practice is located. But of course, I part of the reason I got into the business is to work with people that look like me or come from underserved communities or communities that may not have the most positive image of what therapy actually is. And then certain, I guess, subsections of the LGBT community, of course. Those subsections tend to be a small percentage of the population, but that doesn't mean that the need for treatment is any less. Or that the belief that there is someone providing treatment who understands exists. For example, a lot of people promote themselves as being LGBT friendly. I'm not the biggest fan of that. Because LGBT affirming is very, very different. And so there are people that I've met, clients, who when looking for therapy, if it says friendly, they're not going. And they probably shouldn't.
Can you tell me the difference between friendly and affirming?
Friendly is accepting and tolerant. Affirming is more reflecting pieces of your identity back to you, if that makes sense. You may know people that you accept and tolerate, but you're not going to affirm or encourage or uplift certain parts of their identity just because you tolerate them being in the same room with you. It is a big difference. The marketing should catch up to the difference if it wants to attract the people who actually desire the service.
Respect is a big part of that, isn't it? Like, I mean, I don't have to necessarily go on my way to affirm Juice. Like, Juice is Juice. Mm-hmm. He's he. You know? But I think by accepting or tolerating, you are probably going out of your way not to affirm, right? Like, let's say I know this person is trans.
Sure.
And they said they're trans. They say they're she, but I'm still gonna call them he.
Yeah.
Because they're a man. Like, I mean, like, that's.
I know exactly what you mean.
Yeah.
Okay.
Mm-hmm.
But the key in what you just said is they said they identify as trans.
Right.
You did not assume.
Mm-hmm.
That's being affirmative. Okay.
Mm-hmm.
I'm not going to assume what your gender is. I could guess, but if I really wanted to affirm you, I would give you the space and opportunity to define it for me. Mm-hmm. Teach me how you would like to be respected. Respect can be defined differently by different people. I'm not. If you're going to affirm, you cannot assume.
I like that. If you're going to affirm, you cannot assume. Yeah.
I mean, you can.
Yeah.
I cannot affirm you if I'm telling you who you are and what I perceive you to be. What would be the point of that?
Have you voiced this out loud to other people that you work with in the mental health field? Like,
as far as colleagues?
Yeah.
Yeah, of course.
Is there ever any pushback with this point of view? Because this point of view represents a lot of other people's point of view that they may not think of or be aware of.
There is not clinical pushback. There is capitalistic pushback. As far as, like developing a business that revolves around this idea. Some people do push back on that. But the concept is hard to push back on. Because it is not LGBT specific. The concept is not. If I know you, let's say I know, we have had the conversation about how you identify as a cis man. Even though you are a cis heterosexual man, there is still a specific lived experience of yours that is worth affirming. It is hard for me to understand why or how anybody can truly push back on that concept. If you want me to believe, I assume, that all men are not exactly the same. I hope. So, should I approach you in session as if I know everything about men, so I know everything about you? That would not be helpful, I don't think. So, for me, it's easy to push back on people who push back on the concept of, is that how you would like to receive treatment if you were receiving treatment? Because again, now I'm assuming. For what?
Facts. Yeah.
I wonder if like part of our lived experience though is about making assumptions to keep us safe. And like this doesn't apply specifically to LGBTQ, but like you have to quickly assume in order to determine, okay, I'm gonna go in this store, I'm not gonna go into this store. And so it's
right.
That might be the systemic pushback, right? Because like then we are not assuming anything about anyone. Right. And that might be fear provoking. Like, I mean,
well, I would not encourage you to do that.
Right.
Right. But that's no different than what we're going to teach you anyway, right? Mm-hmm. Anxiety is not always bad. It is biologically there to be an alarm. Mm-hmm. To let you know, okay, that door, it looks like maybe I should not go through that door. Mm-hmm. You are assuming that there's danger on the other side, but you have intuition, you have wisdom. Mm-hmm. You are allowed to leverage it. Mm-hmm. But you don't have that about each individual, especially upon meeting them. Now, after even after 10 minutes, you might be able to determine, okay, this guy, he's an unsafe guy. Mm-hmm. I don't want to continue to engage with this person. Mm-hmm. But just by looking at him, it's harder to do. Not impossible, but it's harder to do.
Yeah. But patterns, like from experience, though.
Yeah.
That informs your assumptions.
It does. But mm-hmm. in session, it's a little bit different. Mm-hmm. Because I'm not informed about you. Yeah. Like there are patterns that inform the way I move through life. Mm-hmm. Yes. Mm-hmm. But I'm not informed about you. Yeah. I cannot bring all of my patterns into this room. I would lose clients. Yeah, you have to come with a blank slate. So, yeah. Mm-hmm. I mean, you would hope. Like, I mean, you have a brain. Like, it's gonna come up with thoughts, but not every thought needs to be engaged. Right. Yeah.
Is that how both of you have had to approach the work that you do between medicine and therapy? Like having a blank slate for each person?
No, I don't think I come in unbiased at all. Like, yeah, my biases are there, but it's about giving the opportunity for the person to prove me wrong. Like, I ask that's why I ask open-ended questions. I'm not just saying like, okay, well, yeah, obviously your child is obese because they have Cheetos every day and you guys don't go out and exercise. I'm like, so tell me about your diet. Uh-huh. And then you prove me wrong because then you tell me that you have Cheetos every day and then I can go
was something you mentioned about the marketing side of taking on that mission. And I know you're looking to start a private practice. Mm-hmm. What are you looking to bring to life with that private practice?
So I do want to provide gender-affirming care because I just want to have an open door to that community. But with the understanding that that's not necessarily what members of that community are going to come to treatment for. It is a space for them, but it is not limited to that. So it would, if you look at any website when you're trying to pick a provider, they'll say that they can address a number of things. The affirmative care would just be on the list. But that person then could address the other items on the list. And then I just want a culturally inviting space. Because even in supporting that community, I've run into things that I don't always know what to do about, how to handle, but that is the goal for me.
By saying gender affirming care, is there something unique to that population that comes up as a mental health challenge, or are you saying like in your treatment of anxiety we will be gender affirming?
So the second one absolutely is a requirement. The first one, not so much. People are people.
Yeah.
Your gender may or may not be relevant in an everyday issue, but if it is relevant, it is easier to, I think, speak with someone who understands why it is relevant.
Yeah.
In terms of that thinking, would you say because there's not a lot of space for that yet, a lot of folks haven't ran into the problems to come up with better solutions? So like, for example, you said, even you yourself, you've come across things and you're like, well, I don't have a solution for that yet. Do you think if there was more practice with that mindset or space for that, someone would have a better solution that could help out the folks that are looking to help community-wise?
Potentially. If you're helping out community-wise, it would be most beneficial to have, I think, a team. Like, this isn't work that I would probably forever do independently. So, for example, things that I've run into that were more difficult. A trans client who is dealing with some shame and rejection from their family, and they're having a hard time explaining the concept of gender. Now, I can explain the concept of gender in English. This person has parents who only speak Spanish. I don't know how to teach you how to culturally explain this in your language, and you're not sure how to do it either. So if I were to build a practice that involved a team, it would benefit the client base and the community to have someone who may be able to address that kind of intersectional issue, because I'm not sure how to do it. It's things like that it's broad. Like, you're a normal human being, you have shame, you experience rejection, and you have a communication issue. But gender is relevant because there is a concept that is hard to explain in other countries, other languages. It is hard. So when I say I want to work with people of color, I mean across the board, but there's going to be cases where other clinicians will be helpful.
Are there ever assumptions about the work that you would like to do? Like, you say one thing out loud and folks assume, oh, you mean this other thing over here? And you're like, no, actually just the thing that I said.
Usually, because if you say gender affirming care, people think that, like, you mean transgender people, and that's not always the case. Because it could just be gender expression. Maybe your mom just won't let you shop in the boys section, and that's really hard for you. Gender expression, even if your gender identity is not changed, like I can affirm your desire to wear what you want to wear. But people have a very like narrow idea of what it means. And so when it comes to like that capitalistic mindset, it's like there are not enough transgender people for you to sustain a business. But that's not what the mission is for. It's for everybody. There's gender expression, gender identity, there's some sexuality overlap, there's a lot of stuff. But you think that if there aren't enough trans women walking around the city looking for a therapist, that there's no business here. And that's just not. That's how we have gotten to the point we are now, where there's not enough business here.
Another effect of capitalism.
I wonder too if we like broaden the language, that would help provide some clarity. Because even for me, gender affirming care means medications or surgery. But what you just said, that is not included in what I have come to know as gender affirming care. It's like gender expression or just like...
Right.
Yeah.
So that level of care is, because you operate in the medical field, that makes sense. For people who are medically transitioning. But there are people who are not transitioning at all, which might just be expression. And then there are social transitions. How do I just get my friends to use the name that I want? I don't want to do anything else. I just want to use a name that I'm more comfortable with. That takes some time.
Yeah.
To build that comfort, to get over the insecurity, to be sure that that is the name. To be flexible enough to say you can change it again if you want to. That takes a lot of emotional and thought process work.
Yeah.
That's awesome.
I mean, it took probably centuries for women to get rights. So I feel like this as a new concept is going to take a long time for it to become well integrated and fully accepted.
But it should include cis women, right? It does not have to just be LGBT for it to be gender affirming. Women have very specific issues and lived experiences. They often need to be affirmed for those things. It should include them too.
Yep.
When it comes to folks who want to do work with you, what are your expectations of people that may reach out to you in the future?
I don't have expectations. I have hope.
Okay.
That you reach out and that you do your best to be consistent in engaging in the therapeutic process. That is it. But I don't have hope. I mean, I don't have expectations. It's unnecessary. It is unnecessary to expect a volunteer to do anything. You are voluntarily coming here, in most cases, and so I don't expect you to do anything. I have hopes for you, but different.
When it comes to your journey, what would you say the favorite part of your journey has been so far?
Which one? Which journey?
Let's say the transformative journey, and then we could do the mental health journey in terms of becoming a therapist.
Okay, my personal gender transition. My favorite part? Talking. I know that sounds kind of crazy, but I did not talk as much before.
You mean your voice?
I mean literally, the people probably would have described me as quiet and shy. I don't think I was. I think I was purposefully quiet, not talking. It was there was a level of confidence that exists now that did not exist before. And for me, that was a combination of the medical part and the expressive part. So unfortunately, I started becoming a therapist and doing the medical part at the same time. So it's beneficial that I talk more now. But I always had things to say. Like I always liked to talk. But now I feel like a people person. Like, I enjoy it. I want to do it. I have no nerves at all about sitting here right now. And that would not have been the case before.
Was it, like before, do you think it was because of how your voice sounded or because of what you might have said that might have been met with rejection?
No. I always liked myself. I never really feared rejection, but expression was not always my choice. It's what you can and cannot do and how you can and cannot present is dictated often, especially when you're younger. And then as you get older, you've done it for so long that you kind of just accept, well, this is how the world works. But then you get to the point where it's like, well, the world works in some ways the way that I want it to. I am not limited in the number of decisions and choices that I can make for myself. So to continue the limitation is a disservice to myself. Because if you had asked me at like 13, would I have transitioned? I would have been like, yeah, of course. Like, very aware of the concept and the desire to do it, but it's how I present was not my choice. It is my choice now.
Yeah.
So you are, I think, naturally quiet when things around you feel repressive.
Right. You don't have control.
Not to the degree that you would like to.
Yeah.
And it's not just that, like, household. It's like a societal expectation. But I just kind of chose not to be bound by it, I guess. And so there's just like a freedom that comes with it, with making choices, and to some degree to just talk is a choice. I enjoy continuing to make a choice.
Yeah. At what age were you released from the oppression?
Of other people or of my own mind?
Both. I mean, the other people in the society were the thing that were mainly holding you back, right? Because you said at 13 you would have said, yes, I want to transition. So at what point were you released from the shackles, so to speak? Yeah.
I mean, I'm sure when I went to undergrad, so like 18, you don't live at home, you're free to make different choices about how you express and present. But I wasn't doing it though. So I still had the desire, I still had the awareness, but I was not doing it. So that is kind of why it's the question of, do you mean other people or my own mind?
Your own mind.
So my own mind, 27. It took a while to unlearn a lot of things.
Yeah.
But most of what you're unlearning is that you don't need to be as hyper focused on what other people think.
How supportive was your family in the transition?
I mean, pretty supportive, all things considered. I don't really have the type of family that pushes back on that kind of stuff. Well, let me see. As time went on, their mind expanded as well. So what they thought about expression and presentation when I was like 6 is not the same level of thinking they had when I was like 30. So I might have gotten a different reaction at 13 than I got now. People mentioned that they were surprised that it was going to be my choice, but I am not shocked by their surprise because I was not talking to them. I did not give them the opportunity to know me on a deeper level because they already told me what I couldn't be. So I did not share much of what I was. So I'm sure you are surprised, but I'll take surprise over like angry or just not on board. Now, as time goes on and some changes become more visible, people still are like taken aback a little bit. But rarely are people bold enough to say anything about it. And I'll take that too, because it doesn't really matter. I mean, it might matter to them, but it doesn't matter to me.
What was your favorite part on the mental health side?
I just feel like it's nice to do something that you care about. I'm sure I was doing great work before for the feds that benefited somebody. I did not go home every day feeling fulfilled about what I did with whatever Word document. I felt nothing about that. At least I get to feel something about what I do now. Some actual purpose beyond just like income. Because it's not the same. Like tech money and mental health money is not the same. And I chose purpose over the money. So I feel like that means that is my favorite thing.
I mean, what you described in terms of like at age 27 being mentally ready or willing to fully live your truth, that is not much different from what a lot of 27, 30-year-olds go through about many things, just like, and that's a commonality that I think people overlook or don't recognize. Like, I mean, just because a person has a title of transgender doesn't make them much different from you or me or, you know.
No.
Yeah.
No. I would say most people between like early youth and early adulthood do think a lot about what other people think. Just in general. So when I get a transgender client that comes in and they've already started the process at like 16, I'm like amazed by this, because I cannot imagine.
Yeah.
I can imagine the willingness, but the strength is hard to wrap my mind around, because kids got a lot to say at school, and it's hard not to take those comments home.
Yeah. I think there's a bigger community at school now, though. Like, if you think back to like 2004 and 5, I don't think that LGBTQ was widely accepted at all in middle school and high schools. But now online, they have their communities. People are more expressive at school, even if they're not doing it at home. And so I think kids have more exposure and acceptance in that way.
I would agree that knowledge and exposure has expanded and grown. The level of acceptance is situational and probably regional.
Yeah, the DMV is definitely further along than a lot of other places in the country.
Sure.
Yeah.
I'm not leaving here. Not if I'm doing this.
Yeah, we live in a nice bubble on this side.
Yeah.
When it comes to, all right, so conversion therapy and all the things that I've been hearing about, especially with the party that's taken over, do you have fear of what the younger generation is going to go through that therapists are going to have to find ways to tackle and figure out? Or do you not worry about that until the time comes when you're faced with that, if you are faced with that at any point?
Do I think there's going to be like an increase in the number of people who are sent into conversion therapy? No. Will people continue to be forced down that path? Probably. It doesn't work. Conversion therapy does not work. But do I worry about them for other reasons? Yes. I do. I worry about things like suicide rates increasing and things like that because of the repressed or oppressive nature of things that they're going to have to deal with. Services they may already be receiving that may be lost, or just areas that they will not safely be able to engage in. But those things are not uncommon. Like there's a resilience to the community that has always found a way to kind of adapt and move around those things that I hope people of my age group, the methods and the techniques that we know, we pass them down. We can let them do their own thing, but pass them down. Because like for this community, I think change is just kind of like inevitable. So you kind of just navigate the current nature of things until you get to whatever the next phase of society is going to be. But yes, I worry about them mostly just because of the language that people use and stuff like that. Yeah, people use just, I don't know, weird language to me. The idea that to be transgender is like not a real thing. You don't want to make some little kid feel like they're not real, or like they must have corrupted thinking because what they believe themselves to be like does not exist. Mm-hmm. That I worry about in terms of like suicide rates, because how can I continue to operate in a society that thinks that like I'm just crazy or like something is actually wrong with me? But I don't worry about us like returning to the days of sending them off to some facility, at least not at higher rates than we do right now.
I feel like what's more likely is that people will go back to the days when there was the down low, or like, you know, their identity was more hidden. I feel like that is probably a more likely outcome than conversion therapy increasing.
It's possible, but I think for some people, not everyone who does that is an adaptability technique. Mm-hmm. It is an attempt to do what you want to do, navigating what you perceive to be the current state of society. Mm-hmm. And we have always done that in some shape or form.
Yeah.
That one probably will always be a thing. Because the language that people use perpetuates the opportunity for shame and denial to persist.
Yeah.
Do you have any other questions? Appreciate you.
Of course.
Finally got to have this talk.
Let's give it up for Dani.
Let's go. Appreciate you, Dani. All right, well, this has been another episode of Mental Health Monday. Appreciate everybody for pulling up. Like, subscribe,
share, and comment.
Let's go. Appreciate you. Here we go.